Welcome, everybody, to our woman to woman interview. And I'm super pleased to introduce you to Dr. Angela DeRosa. And Dr. DeRosa is from Arizona, and she's known as Dr. Hotflash, and we're going to dig into a little bit of why she's known as Dr. Hotflash, but we're talking about menopause this month. And so Dr. DeRosa is an expert in this field. So we're going to just let it roll. So can you tell us how you got, just briefly, how you got your nickname, Dr. Hotflash, because that's the name of your
Yeah.
website, correct?
Yes,
Okay.
drhotflash.com. It actually started with a group of my best friends. They just because I actually treated my best friend early on, and when I realized I really liked her as a person and wanted to be her friend, I couldn't be her physician anymore. So I fired her, and then she started seeing one of my colleagues. But she was the one that actually coined it. She goes, we should really just start calling you Dr. Hot Flash because you make women feel better with all their hot flashes, and it just kind of stuck. And now I've got it trademarked, and I love it. So.
That's awesome. Oh, you have it trademarked. That's
Yes,
perfect.
yes, yes, yes.
So tell me, in a nutshell, I know there's no nutshell when it comes to menopause because
Oh,
there's
yeah.
so many different symptoms, and I know hot flashes are only one of them. Can you tell me what I know you're super passionate about spreading the word about helping women. What is your message to women, like, about menopause and about perimenopause, and
Mm.
how we should be equipped to handle this change in
Okay.
our lives?
Well, there's so much misinformation about menopause, and also there seems to be this idea that it's just something that all women are going to go through, and we have to accept it and deal with it. But when we think about the counter, so if men were to walk in with all the symptom complexes that we have into an office, they would get appropriately treated. The urgency would be there. They get their testosterone products, their erectile dysfunction, they have whatever workups they need. But for some reason, women get dismissed. And a lot of it is because there's a lot of lack of understanding clinically about how to manage hormones in medicine. We're not proper, so physicians and folks aren't properly trained to understand a lot of it. So instead of acknowledging that that deficiency exists, they just poo-poo everything and they just kind of give all the conventional things. And unfortunately, instead of getting the products women need, we get thrown on antidepressants or told we're crazy or told we have fibromyalgia and all these wonderful things that just put us down this pigeonhole that then we're not taking seriously anymore. So there's a tremendous amount of gender bias, and it really takes women screaming and advocating for their own health. And what I tell women all the time is if you know something's wrong, trust your instincts, trust your body, because there probably is, and keep pushing until you get the answers that you really deserve. And unfortunately, there is this misinformation not only about how to properly manage hormonal medicine and what perimenopause and menopause is, but also they create a lot of fear about hormone therapies and things that really women need in order to properly get through that and transition beautifully in it, because we're going to live a third to a half of our lives in menopause now. We used to die before menopause. Now we're in menopause a long time, and I want to live that optimally. And it's not that we're just trying to get rid of women's hot flashes, because when you start to think about the whole symptom complex, which I'll review here in a moment, it's not about just doing that. It's also about restoring hormonal levels in your body that gives your body the proper tools to function optimally. So that's how restorative medicine, optimal medicine, all of that's and functional medicine, it's all about the concept. But it's not just about improving symptoms, but giving your body the proper tools to optimally function so that you prevent chronic illness, you prevent the cancers, and you live a long, healthy life. It's one thing to live a long time, but let's do it and do it well. So, and I'm rambling here, but what's important is when we think about hormone deficiency, so you brought up the hot flashes, the night sweats, the insomnia, those all are estrogen deficiencies. But there's also mood disorders that come from that. Our arteries get hard, which lead to high blood pressure. We start to lose our bone, which leads to osteoporosis and bone fractures. We get vaginal dryness, which leads to painful sex. We get more allergies because not only do our vaginas dry up, but so do our mucous membranes. Our eyes get dry. Our skin starts to itch. So there's all these things. But the other side to that coin is the most abundant hormone in women is not actually estrogen, it's actually testosterone. And it's not just a man's hormone, and it's not just about sex. So it does improve our libido, our desire, our clitoral sensitivity, our orgasms get stronger. But testosterone is essential for mood. So you'll get panic attacks, anxiety, apathy, all of that. When you lose your testosterone, you'll get migraine headaches, you'll lose bone, you'll get more inflammation, which will lead to cancers, including breast cancer. And testosterone's most important role is it helps us process and move sugar into the muscle so it can burn clean, which if we don't have, we gain weight in the midsection, and then we get insulin resistance, which leads to heart disease. So this is serious stuff.
Woo!
Yeah.
Okay.
I can take a deep breath now.
Okay. All right. So yeah, testosterone. I mean, I'm aware of the testosterone piece, but I wasn't always. And I know that there are a lot of women that think, I'm going to get facial hair, or I'm going to like my muscles are going to get too
Oh
big.
my
And
gosh.
yeah,
So if
so
I were to give you men's doses, so men make 10 times the amount, although testosterone is our most abundant hormone, men still make 10 times more than we do. If I give you male doses, of course I'm going to give you hairy, I'm going to turn you a hairy Sasquatch guy, and you're going to be big muscle. But women, we already make naturally a lot of testosterone. If I replace it back to that normal level, abnormal things shouldn't happen. But let's also put things into perspective. So I always tell patients this. So if I were to give you $1 million, but I asked you to mow the lawn once a month, or $1 million house, and I asked you to mow the lawn once a month, would you take the house? And they go, well, of course I would. Well, okay, so let's say you no longer have migraine headaches, you have your libido back, your energy's back, you have great mentation, you feel great, you have all these wonderful things occurring, but you're worried about a chin hair? I mean, come on, put it into perspective.
no, yeah, I was kind of blown away. I didn't realize the percentage of testosterone that we produce as women. That kind of blew me away. I heard your interview on the Get Foxy show, which is what brought me to you, because we were both interviewed there. But I heard that that's the first time I've heard that, and so I didn't realize we make that much
Oh,
testosterone
it's a
naturally.
ton. And we make actually on a day-to-day basis, it's almost 10 times as much testosterone than we do estradiol. Mhm.
Mind blown. Okay,
Yeah.
so you touched on all those, you threw out all those symptoms, right? So um, I have so many questions to ask you. So first of all, when when women go to their doctors and they get prescribed antidepressants,
Mhm.
what do you think it's a lack of knowledge, or do you think that the doctors are afraid to prescribe hormone replacement? Because we can talk about that whole fear
Yeah.
factor in hormone replacement, and is it the Women's Health Initiative,
Yeah.
that whole piece
Yep.
of it? Because I hear a lot of my patients are very, when I talk to them, like, you might need to get some hormone replacement, they're fearful of it, and
Yeah.
this fear has been like brewing about hormone replacement, and so I want to touch on that a little bit.
Yeah, and here's what's so crazy to me is that study came out in 2002, and we're 20 years later, and the damage is still prevalent from that study. When they put that study out, they first off, the data that came out right from the get-go was incorrect, and they had to correct it. And there have been multiple research articles that have gone through and done the corrections. They've done mea culpas on a lot of the information they put out, but unfortunately, that information is not what is predominant in people's minds, including physicians. But let's go back to that study for a minute. And really, there was a lack of understanding. And the way they presented the data to the public was designed to incite and fear in people. And to give you the example, so if you hear you have a 25% increase of getting breast cancer while on hormone therapy, people are flipped out. They think 1 in 4 women who are on hormones, Premarin and Prempro, which were the drugs that they were studying, the worst synthetic estrogens and progestins possible, but which we don't use largely anymore. But so if you hear that, of course you're going to be, oh my gosh, 1 in 4 of us are going to get breast cancer. That was horrible statistical manipulation, because it was basically what we would call in statistics, you have an absolute risk and a relative risk. A relative risk is a percentage, and then the absolute is the actual number of patients that are affected. So, but when you actually look at the actual numbers of patients that were affected, it was actually one patient more in 10,000 women. That is
Oh,
actually,
wow.
that sounds way less scary than 25% when you actually look at the statistical relative risk. But what's interesting is that was only the Prempro arm. But when you looked at the Premarin arm, actually it showed benefit for being on Premarin for breast cancer risk. But that was information was buried from the get-go, and that would have been really reassuring, don't you think?
Yeah.
So they manipulated it right out of the get-go to create fear, and unfortunately that has continued. But when you look at all the data in whole, so I'm going to try to condense all the last 20 years of all the publications and what they actually found. So the Prempro, so the horrible progestin, when they actually looked at the original data set, it showed this 26% increase of breast cancer, which was actually 1 in 10,000. But when they corrected the statistics, it actually went neutral for breast cancer. So that's what's actually the worst one, was neutral breast cancer. Premarin showed a benefit at baseline. When they corrected it, it still stayed beneficial. So when you look at the breast cancer risk overall from those two drugs, the worst case is you have a neutral risk. So you could be on hormones or you could not be on hormones. You're still going to have the same risk of getting breast cancer because of other things, which actually more women get breast cancer from lack of vitamin D, having a college education, sedentary lifestyle, drinking too much. I mean, there's all these other things that lead to breast cancer, but everyone wants to be afraid of hormones, and they refuse to quit drinking and doing all their other things.
Right.
And then the Premarin arm stayed positive the whole way through. So their fear is misplaced. And what's even more interesting is, I mean, we don't even talk about it, is testosterone's role is very breast protective. And there's great research coming out of Dr. Rebecca Glazier's research that's showing that even women who are actively undergoing breast cancer therapy can go on testosterone with estrogen blockers and actually get their lives back and have a reduced recurrence rate. So testosterone is highly protective and beneficial. So women, when hormones are done properly, your risk isn't going to go up. Your risk is going to come from having inflammation in your body, from exposures, genetics, all those other things. And when hormones are properly done, your risk is neutral to positive at best, if you want to look at that study specifically.
Okay. All right. Just bringing up more questions.
I know. It's a rabbit hole, isn't it?
Yeah, it's great. So lifestyle, you touched on lifestyle, right? Like what you eat, movement, like doing all those things, taking good care of yourself is really important.
Yeah.
And I know that when I was going through perimenopause, in the beginning, I was like just trying to do things naturally, like, doing acupuncture or, herbs or
Yeah.
maca root and, all of that kind of
All
stuff.
good
So
stuff. Yeah.
can you, and I guess there's this part of me that's like, oh, we should grow old gracefully, and this is what your body is meant to do at this point in your life, right? So I had
I'll argue that point a little bit, but
what?
I'll argue that point a little bit, but I'll let you finish your thought.
Yeah, no, I just for people that are thinking, oh, this is just my body's natural process. Why should I go on hormone replacement, or why should I do this? I'd love for you to touch on that
Well, and you certainly
aspect of it.
can. I mean, but you certainly can. But when we're going to live a half to a third of our lives in menopause, do you want to live it feeling lousy, or do you want to feel it living well? And again, so let's think about the biological purpose of things. And I always try to go back to simple biology and Mother Nature. So Mother Nature never intended us to have babies after the age of 50, which is why she shut our ovaries down then, because God forbid we're getting pregnant at 60, 70, 80 years old and we can't care for a baby. Men, on the other hand, continue to have sperm well into their 80s and 90s, can father children, and they're about propagating the species, which Mother Nature wants. But for us, once we have our children, they're okay. It's like, okay, we can do away with you. You know what I mean? So we're not supposed to carry babies, because it's not only unhealthy for us, because we wouldn't be there to care for the child through hopefully their adulthood, but also it puts that child at risk for having problems during that childbearing. So Mother Nature purposely shut off our ovaries so we can't get pregnant at a certain time. However, there's an unintended consequence, which is really unfortunate. She's also shutting down the production of those hormones, which are vital to our vitality and our overall health. And we need those hormones to function properly. So if you want to just quickly start to age after that, go right ahead. I mean, that's your choice. But I want to restore back those hormones to give my body all those tools to function optimally, so I continue to live and function at my optimal while I'm in that time period. Because now we used to die before menopause. It's just now we're living so much longer, which was never intended based on original biology and Mother Nature. But also to illustrate this point, and I use this a lot with clinicians, but I'll try to simplify it a bit. But when you go to see a doctor, let's say you're gaining 100 pounds, you're tired all the time, you're constipated, you're cold, you're basically on death's door with fatigue. You walk in and they're going to check your thyroid levels, which is very something common they're going to do. A TSH is the most common thing that most conventional doctors check, thyroid stimulating hormone. That hormone goes really high, skyrockets when your thyroid fails. Because think thyroid stimulating hormone is a whip. It's the brain secretes this whip to go beat the thyroid into making the thyroid make hormone. So if the thyroid's not responding, the brain's going to keep going and beating it harder and harder and harder and pumping out more TSH to get the thyroid to respond. But if the thyroid's saying, heck with that, I'm not doing this because it's maybe has Hashimoto's or whatever thyroid disease, but the brain's not going to care. It is going to attempt to beat the heck out of that thyroid to get it to do its job until the thyroid responds. So TSH drifts. So normal is under 4. I mean, well, optimal is 1 to 2, but endocrinologists say anything over 4 is abnormal. If you're feeling in the way I described, usually your thyroid is going to be markedly elevated, 10, 20 in some cases. And by the time it gets to 100, you're in a coma. So I want you to use that now in perspective. So now the brain has a similar whip called FSH, follicle stimulating hormone, which does the exact same thing, but to the ovary. It goes down there and beats the heck out of the ovary. So go make estrogen, make testosterone, do all these wonderful things. Make follicles so you can get pregnant. Well, when the ovary shuts down at menopause, the brain still wants the ovary to secrete those hormones. So it's going to keep beating it, but it's beating a dead horse. So FSH goes up and up and up and up and up. So normal is 5 to 10, let's just say in most women during certain times of their month. And menopausal women often walk in, when their ovaries are shut down, the brain's coming in, the FSH comes in at 100. And that's the brain telling you it is pissed off that the ovary is not working and it wants your hormones. And that FSH level will stay elevated like that till the day you die if your brain is functioning properly.
Wow.
So if it was normal, your brain wouldn't try to fix it. But you walk into a doctor's office with a TSH of 100, they are going to get crazy and immediately fix that. But we ignore the FSH.
Wow.
Biologically, that doesn't make sense.
Okay, I never thought of it from that perspective. That's really interesting.
Yeah.
I didn't realize that it's going to just keep
going and going and going.
That's a powerful
this is how I
image.
try to argue with physicians who don't agree
Yeah.
with me about this. It's like if this was normal, the brain wouldn't try to correct it.
Yeah.
Mhm.
And there's so many health benefits to getting that support, right? I mean,
Oh,
there's,
absolutely.
the risk of
Prevents high blood
Alzheimer's
pressure,
and,
prevents blood pressure, prevents osteoporosis, prevents cardiovascular disease, prevents insulin resistance and diabetes. I mean, you name it. It prevents cancers, dementias. I mean, I could go on and on and on. So,
amazing. So can anyone at any time from perimenopause to menopause have hormonal replacement, or is there like a cutoff age or time that like it's you missed the boat kind of thing? Or
no, there's always something you can do, but there are certain things we have to address. So we start to manage and balance hormones. So you don't necessarily have to be 100% deficient. You could just be suboptimal. So we want to, as you start to move into perimenopause is when we start to replace the hormones or balance them out. And then when you get into menopause, when the ovary stops making those hormones, obviously we're replacing the hormones that the body's no longer making. Now, let's say you have a woman who comes in and she's 65 years old and it's been 15 years since her menopause and she's not been on any hormone therapies. We can safely start testosterone on that patient. However, I'm going to take a pause on estradiol. And the reason is because of one of its main effects. So estradiol keeps our arteries and veins really pliable. They kind of keep them elastic. But if you take that estrogen away, those arteries start to harden, and which leads to the high blood pressure, but also you start to get plaque buildup within those. So if I were to take this 15-year-old artery that's got all this stiffness and plaque inside of it, and all of a sudden throw estrogen on it, that estrogen is going to attempt to repair that, which it's supposed to do. Well, that first year during repair, there's a risk of it kicking off some of those plaques until the year passes. So that first year, their risk of heart attacks and strokes and those kind of things related to that goes up. But once you get past that first year of repair, then actually their cardiovascular risk drops. And then by year 5, it's actually lower than patients who aren't on hormone therapies. But that first year is tricky. So if you have patients who are already high risk, you're putting them at additional risk. So I would avoid estrogen in some of those patient populations. Or if we can't get a lot of their symptoms under control with just testosterone and vaginal estrogen, which just does it locally, then we'll have a hard conversation about how do we mitigate that risk. Do we put them on beta-D aspirin? Do we put them on CoQ10, red rice yeast, all these different things that can help with that? Or a new supplement that I started using, arterial cell, which helps with the endothelial glycocalyx, which is a new exciting part of medicine now. But so there's things that can be done, but ideally in those patients, I would just start testosterone and vaginal estrogen if needed. So testosterone usually is always on the table for me with rare
Okay.
exception, but estrogen after 10 years, you have to use a little more caution.
Okay. Let's see. So how would someone know who to see, what to do,
Yeah.
what kind of support they need? I know you work with people remotely, correct?
Yes. So the good
Okay.
news, right, so a couple of good things that came out of the COVID pandemic is telemedicine rules have gotten a lot more liberal. So folks can contact my clinic. There's actually information about my clinic on my website, Dr. Hotflash at the bottom. You'll see that. They can see my nurse practitioners who have been trained by me and get the care that they need telephonically through telephonic consults, or people fly in to see us all the time. But if they want to find someone in their local areas, good ways to find folks. First off, look at their website, see if they talk about restorative medicine, functional medicine, optimizing health, bioidentical hormone replacement therapy. So those are some tag words that they should be looking for. Or they can even call local compounding pharmacies, or the one that I work for, Belmar Pharmacy, which is out of Colorado, calling those folks and say, hey, who in my area does this and does it really, really well? So you can use those resources to track down folks in your area to get to the right people, because going to the wrong people is really problematic. And
Sure.
you could end up not only not getting the care you need immediately, but also affecting your long-term health. So,
Right.
mhm.
And are blood tests usually the protocol? Do you do the Dutch test? What's
So
the
there's lots of different, you're going to hear some folks like the salivary testing, some do urinary metabolites. I'm just a good old fashioned. I love my serum. I can get the majority of information that I need from serum, looking at estradiol levels, FSH, total testosterones, my thyroid panels, TSH, T4, T3, reverse T3, prolactin levels. I mean, there's a whole host of things I can do, but usually how we start is we do questionnaires. So there's a MRSA, which is a menopause rating scale questionnaire. We do a full medical intake. We do a full panel of blood work, and we take all that information and talking to the patient and come up with a tailored treatment plan. And then following how they're doing with those questionnaires, how they're feeling, and then follow up blood work. So you shouldn't just get something and say, oh, we'll see you in a year. You really need to get it dialed in and make sure that it's getting treated properly.
Sure, yeah, that's something
Mhm.
I've been struggling with. I've tried
Yeah.
the creams. I wasn't absorbing them. Now I have a
Yeah.
patch and I'm taking oral progesterone
Yeah,
I guess
there's
it's
all kinds of things. There's now like
yeah,
creams, patches. There's a sublingual that
right.
rapid dissolve tablets. There's pellet therapy, which is the gold standard. So there's all kinds of ways to deliver hormones, but as long as they're bioidentical.
Right. And so you just for our listeners or our viewers, can you tell us what compounded means in a really quickly? I
Yes.
know we're running low on time, but
Yes,
I don't
and there's a big push, just as a too. There's a big push to eliminate compounds because the FDA wants to deem them not clinically a need for them, or that they may be dangerous, which is nothing
Mhm.
to be further from the truth. So compounds are not being done by rogue pharmacists. These are highly trained pharmacists who know what they're doing, and they're regulated by the state boards, their medical boards, the DEA, the FDA. I mean, there's heavy regulation in this space. But also, compounds are very safe. So the analogy I like to use is if you were to go into a restaurant and you look at the menu, you order your menu, you say, I want this for dinner. So you can either go to McDonald's and they're going to give everything's going to come out in just like a mass production.
Mhm.
That's your synthetic pharmaceutical big pharma company hormones. They're mass production like McDonald's. They're coming out one size fits all for everything. But if I were to go into, say, a really fine restaurant, French restaurant, and they're going to create this meal for me, that's what a compounding pharmacy is. So there, you're basically going to the menu. We're picking all the different ingredients we want. We send back those ingredients to the chef. He then is picking out all these ingredients off the shelf and then putting them into a meal and then serving it up to you. Now, what's interesting is when the chef goes back to get his ingredients, he's getting the same ingredients, say, so the way I look at it is big pharma buys buckets and barrels full of, let's say, progesterone or
Mhm.
testosterone base, and then they mass produce their product and send it out. Well, compounding pharmacists buy smaller versions of those same FDA approved ingredients, but compounding pharmacists are just like a little meal, grabbing a little bit of this, a little bit of that, and putting it in a specialized, unique formulation for yourself. So do you want McDonald's or do you want a specialty meal? I vote for the specialty meal. Well, occasionally McDonald's, but that's on a rare bad day.
So, so I'm on an estradiol patch. That's not bioidentical then, right?
It can be. So it
Okay.
doesn't have to be compounded to be bioidentical. All
Okay.
bioidentical means does it mimic exactly what your ovary makes. So the estrogen the ovary makes is 17 beta estradiol. Actually, Vivel.patch, for example, estrace cream, they're made out of big pharma companies, but they're bioidentical. They're just
Okay.
mass produced. Or I can compound a biased product from a compounding pharmacy and it will have a bioidentical 17 beta estradiol in it. So know that it's really the molecule we're looking for. And but unfortunately, a lot of the big pharma products aren't bioidentical. But there are some. Mhm.
Okay. Good.
Mhm.
Is there anything else that we didn't cover that you would like to
Well, I
make
would
a
just want to
statement about?
say that just trust your instincts and trust your bodies. Don't stop. Ask questions. Keep going until you get what you think you deserve and want, because we deserve better. And unfortunately, conventional medicine is not delivering that to us right now. And the only way it's going to change is by patients keeping pushing back, because the medical profession is very slow to move. It's going to demand our patients demanding better from us. So that's what I say.
Yeah. And just bringing, thank you so much for bringing this awareness and for this
Mhm.
quick mini course here
Yeah.
on hormones. And so if people want to reach out to you and work with you, how would they find you?
Everything, the all roads lead to drhotflash.com. So on that is there's a link for medical professionals to learn more about how to train with me. There's information about my clinics. There's also a link to my book. There's articles, blogs, videos. So everything that you could possibly want is on that website. And also and again, so not only go to my website, but go to savemycompounds.com and learn everything you can about what's going on. But that's the best place to start.
Awesome. Thank you so much for
You're
this
welcome,
amazing
Michelle.
presentation. I've really enjoyed talking to you. And
Definitely.
yeah, so